A 34-year-old man presents with multiple painful ulcers on his penis. He says that the ulcers all appeared suddenly at the same time 3 days ago. He reports that he is sexually active with multiple partners, uses condoms inconsistently. He is afebrile, his vitals are within the normal limits. Physical exam reveals multiple small, shallow ulcers with an erythematous base and without discharge. There is significant inguinal lymphadenopathy present. Which of the following is the most likely etiologic agent for the patient's ulcer? Is it HPV, chlamydia, Treponema pallidum, Haemophilus ducrei, or herpes simplex virus? Okay, so once again here, answer was herpes simplex, multiple painful ulcers, and the whole sexual history, lack of condom use, multiple shallow ulcers with an erythematous base and without discharge. And once again, significant inguinal lymphadenopathy. So if you just recognize these 2 points, the question becomes extremely simple. So once again, the patient most likely had ulcers caused by HSV2. It usually causes multiple vesicles that later they burst to form ulcers, which are painful, multiple, and grouped. They have an erythematous base, they have no discharge, inguinal lymph nodes are enlarged and palpable and painful as well. Okay, most people in the US are seropositive for HSV and the lesions are recurrent. They may remain latent for years within the nearby ganglia. Genital lesions, ulcers are broadly divided into painful and painless. So we'll go over the table. We've gone over this table showing us painful, painless quite a few times in the past, but we'll go over it again today. H. ducrei. I think for this one, someone had answered H. ducrei. So it also does cause painful ulcers, which are usually single, irregular, dirty looking and frail with a grayish base and a tendency to bleed easily. Okay, so Haemophilus ducrei, what you need to know, okay, the ulcers are dirty looking and frail, unlike the red shallow base, which is seen with the herpes simplex. And another thing is about Haemophilus ducrei, which would be helpful to know, is that the lymph nodes, they form buboes, so they can have exudates, which is unlike the lymph node lymphadenopathy of herpes simplex. So that's another thing we'll go over. Okay, Treponema pallidum, chlamydia, and Klebsiella. These are all painless. All these 3 cause painless ulcers. So painless ulcers is syphilis, chlamydia, and Klebsiella. Painful is herpes simplex and Haemophilus ducrei. The chance of Treponema pallidum, the chancre of Treponema pallidum is usually single, clean base, regular margins without any discharge. In addition, the chancre of Treponema pallidum usually resolves spontaneously. LGV is characterized by massively enlarged inguinal lymph nodes and is sometimes called genital elephantiasis. The ulcers are painless, they heal spontaneously. Granuloma inguinale is a red beef-colored ulcer that does not dissolve spontaneously but increases in size, causing necrosis of the surrounding tissue. So LGV and Haemophilus ducrei, they cause the large ulcers which can turn into buboes. Okay, HPV commonly causes the cauliflower-like growths that we just saw in the previous question called condyloma acuminata. LGV, once again, the massively enlarged inguinal lymph nodes, it's called genital elephantiasis. Treponema pallidum, single painless ulcer of primary syphilis, resolves without treatment. Chancroid of ducrei is painful, but is typically single, irregular, dirty-looking, frail with a grayish base. Okay, so this would be your giveaway for a chancroid with a tendency to bleed easily. Okay, now having gone through that, let's quickly just go over a few. Okay, so I'm going to start with this table because this is actually just the most important thing you need to know with this question. The infectious etiology for genital ulcers. So like we said, it can be painful or painless. Painful would only be the HSV and Haemophilus ducrei. So I'm sure all of you must have gone over this in your first year. They give the mnemonic with Haemophilus ducrei, you do cry. Okay, so that just goes to tell us that it's painful and HSV is painful. So HSV, multiple small, you can refer to this picture on the left for for HSV. These will be multiple small grouped ulcers with an erythematous base. They will be shallow based with tender lymph nodes, most common in the US, and recurrence is common. And Haemophilus ducrei or the chancroid, this is single or multiple. So our question in the explanation we just read, we did read that it's single, but typically it can be single or multiple. These are deep ulcers, unlike HSV, which is shallow, with irregular and ragged borders. The base may be friable and have a grayish yellow exudate. So like I said, that would be the giveaway, sorry. That would be the giveaway here. and matted lymph nodes can separate or rupture. So like I told you, this is what we call the buboes, which can be seen with Haemophilus ducreyi or with LGV. Okay, so just this picture kind of helps remember some of the features of Haemophilus ducreyi. So you can see this person is crying, so that tells us it's painful. You can see these yellowish spots, so that kind of clues us into the fact that it produces a grayish, dirty discharge. And you can see the irregular borders here. So that's just something to help remember. Painless ulcers, syphilis, single indurated, well-circumscribed painless ulcer with a clean base and non-tender lymph nodes. Okay, the tender lymph nodes are seen in HSV, Haemophilus ducreyi, and LGV. Treponema and chlamydia have painless non-tender lymph nodes. Chlamydia trachomatis, which is LGV, small shallow ulcers, matted lymph nodes, large painful fluctuant buboes, and sinus tracts. Okay, so LGV and ducreyi will have the matted lymph nodes. And Klebsiella granulomatis, extensive progressive nodules which form the beefy appearing lesions with bleeding, and the base may have granulation-like tissue, which is in the name itself. That shows us it can have granulation tissue. Just another quick thing that I want to go over is about HSV and how it remains latent for the longest time and then is reactivated if there's any immunosuppression. So transmission is by mucosal viral shedding, which leads to sexual or perinatal transmission. Then is the initial infection with retrograde transport of the HSV to the sensory nerve ganglia. So from your skin, it travels in a retrograde manner and goes to the sensory nerve ganglia. Okay, and then that is where it becomes latent. So latency is maintained by immune surveillance, immune control of the virus is also present at the mucosa. So it remains latent in the ganglia, and then there's reactivation from latency with mucosal shedding and lesions, and the virus travels in the anterograde manner to the skin or the mucosa. So from the ganglia, it will then transfer on reactivation to the skin and form new lesions. So if you just know that much, that should be more than enough. Okay, just one more thing that I think it can be high yield. This is pretty much everything we've gone over. I just want to go over the treatment. Okay, so just refer to the last 2 points here. Most patients can be treated with oral therapy. We prefer oral valacyclovir rather than oral acyclovir or famciclovir. Even though these have similar efficacy, the oral bioavailability of valacyclovir is the highest, plus it is dosed less frequently. Okay, so that would be a key thing to remember. That is something that can come up in questions sometimes. And another 2 indications that you need to know for valacyclovir is that it's given for those with severe and frequent infections, that is people who have 6 or more recurrences per year, and patients who want to reduce the risk of HSV transmission to an uninfected sexual partner. So these people can go on chronic valacyclovir therapy. So these are the indications for valacyclovir. This is important, it can come up.
Thanks for watching. Please give a thumbs up and subscribe for more.